Hey, and thank you very much for being here. I do appreciate your time. I know that on a hot afternoon you could be anywhere doing anything, but we are glad that you're here to hear about what we talk about. I've had the good pleasure of knowing Cory Hale, actually from a member of a local networking group here that I'm involved in, BNI. Cory and I got together with my business partner Jason Ward and started discussing strategies for which we could help each other. Cory's an expert in OSHA, workplace safety, and things of that nature. He works with businesses to make sure that they are taken care of with their employees. He is the go-to guy for most business owners if they have employee issues. They talk about safety, ergonomics, and things of that nature. And Cory does a great job with these groups. In the process of working with those groups, he realized there's some problems, which he's going to speak about in a minute, and was looking for some solutions. We were fortunate enough to come together and meet so we could put together some solutions for these musculoskeletal issues. So it's my pleasure to introduce you to Cory Hale. Cory's with Green and Safe. Hope you'll give him your best attention, and we appreciate you coming and speaking to us tonight, Cory. Thank you.
Thank you, David. The slideshow is his. I'm going to be here. Is this where everyone can see? Probably not on that side of the room. Can you see that far?
Yes.
Good. All right, on your advertisement for the session today, David highlights some potential cost factors with employees at work when they suffer from acute or chronic pain, and the related healthcare costs, the attendance issues, sometimes the tardiness that goes along with that. Our particular interest as a company has to do when the chronic or acute pain is the result of some work-related incident or work-related condition that they might have experienced either in some kind of acute situation or over a period of time. And that is of interest to us because it's of interest to our customers that we work for, some construction contractors, some manufacturers, some distribution companies, a trucking company here or there. But there is a unique set of consequences when health condition develops that's related to work. And some of you are probably, I know some of you are in the insurance business, so you're probably familiar with these terms, but does the acronym EMR ring a bell to anybody? Experience Modification Rating? Is that familiar? Ma'am? What did you say?
Electromagnetic resonance?
Oh, well, that's a good enough guess. It's actually Experience Modification Rating, and it's a number, it's actually a multiplier that's used by workers' comp carriers, those that underwrite the policies, to determine premium cost, so that they have all these actuaries and they do all these studies and they come up with a formula that determines that the average EMR should be a 1. And based on your loss experience, that EMR goes up or down. It goes up if you have either frequent workers' comp claims or you have infrequent high dollar claims. And if you go a period of time without those types of incidents, then that number goes down. And let's just say that it goes up, say it goes up to a 1.7 or a 1.1 or somewhere in that neighborhood. What that means just for the premium cost is that the employers are going to pay at their renewal 10% more than they would had they been able to stay at a 1. And if it drops down to a 0.9 or a 0.8, then they'll pay 10 or 20% less. But that's only part of the cost factor. For a lot of contractors that we work for, that number is used to grade their risk. Say they want to work in a factory or a manufacturing facility or a distribution center, they want the contract to do the maintenance or maybe a big construction project. Well, the project owner is going to look at their loss experience and grade them and say, well, if you're at a 1.07 or a 1.2, or some of them get really high, 1.3, 1.4, then you must have a pretty poor safety record. You must not be that committed to workplace safety, so we're going to disqualify you and you can't work here. So that money is actually a whole lot more. It's exponentially more than just the cost of the premium increase. Another number that's used to grade them is something called a total recordable incident rate or total recordable case rate. And that is not directly to workers' comp, it's related to OSHA's record-keeping law. OSHA has this 1904 standard that tells all employers, regardless of whether it's an office or a manufacturing facility, that you have to report your injuries every year on a form called an OSHA 300 log, and those of you related to human resources probably are familiar with that. But that log is used to create a summary, and from that summary, you come up with an incident rating that's based on a formula that multiplies your man hours. So that if you're a company with maybe 30 people working for you, and you probably have around 60,000 man hours a year, and let's say you have 2 recordable injuries, what OSHA would define as a recordable injury where you have to receive medical treatment, then you figure your incident rate, 2 injuries times a multiplier, a constant multiplier of 200,000 divided by your man hours of 60,000 to get your incident rate. And I'm not real good at head math, but I think that's probably like a 3.33 or something like that, 60,000 into 200,000. So you would end up with a total recordable incident rate of a 3.33. Well, that number is also used to grade people who want to work in various facilities, and if it gets above a certain point, then you're also disqualified. So there's an incentive for employers to keep their injuries down, not only because of the cost impact on their premium, but on their ability to get work. And that's where they bring us into the picture, because if they're having loss experience over a period of time, they want to know from the safety experts, what can we do to prevent these accidents so that we can control our cost and continue to work in the places that we want to work. And there's a lot of different ways to go about that. I was in Louisville, Kentucky a couple of weeks ago where there was actually a fatality. It was a contractor working inside of an open excavation. The walls collapsed while they were about 12 foot deep. It trapped both of them, and for several hours actually, and there was a 50-year-old man and a 20-year-old new guy that had just been there for about a month, and the 20-year-old new guy died face down in that trench. And so when we go after the solutions for that kind of workplace accident, we focus on trench and excavation safety. It's not quite engineering, but it's a little bit of that with soil classification and the protective systems and everything that you need. But those are well, they're in the United States, there's about 5,000 a year that actually turn into fatalities, but there's about 4 million injuries every year in the workplace that are short of fatalities. And when it's a particular safety violation, like not having trench protection, we know how to go about it. We can help them solve that problem so that it doesn't happen again. But it is also a recordable injury that if you have a 60-year-old guy named James Dolan, which is one of my first experiences with this that prompted me to contact David Grigsby and the kind of work that he does. When James bends over to pick up an angle grinder off the floor and he freezes right there and can't stand up again and hobbles out to his car and tells his supervisor, "I hurt my back picking up that tool," that's also a workplace injury, and it's recordable. And it goes on the OSHA log, and in his case, it ended up being about $60,000 in claim costs that affected the EMR, the first number I showed you. No safety violation at all, but he bends over and he picks up a tool and he has an injury at work. Well, that's tougher for a safety professional to solve because you can't tell him to stop picking up tools. He still has to pick up tools. You probably see this all the time in your profession. There's better ways to pick up tools, but you still have to pick them up. And it's the kind of work that they do, whether they're construction workers or they're on an assembly line in a manufacturing plant or they're driving a truck and bouncing all day long, that kind of trauma that they experience over a period of time, it's a contact sport, and it wears out their bodies. And that's on top of whatever they're doing at home, you know, falling out of deer stands and playing softball and tearing up knees and all the other stuff you see. If you have a torn up knee from a softball injury, and then you come to work and you aggravate that knee injury, then the employer owns it at that point. They'll end up with those claim costs for any subsequent treatment that they have to have. And so we, as a company, started looking for ways to solve that problem. And one of the first things we attempted was introducing some stretch and flex routines into the workplaces for the customers that we have, when FedEx Forum was being built, the contractor, Mortensen, I think was their name, they were out of Minnesota, that they had a picture on the front page of the Commercial Appeal, and they were showing that they were committed to workplace safety, and they had gone all these days without a lost time injury, and one of the secrets to their success, they said, was that they introduced a stretch and flex routine for everybody on site, whether they were skilled carpenters or broom pushers. Everybody had to show up at 6 o'clock in the morning and do their exercises, and they'd line them all up. And the picture on the front page of the Commercial Appeal was a big old guy wearing overalls, a beard like Grizzly Adams, and he was doing his arm circles, and he had a coffee cup in one hand and a cigarette in the other. And I thought, well, there's your workplace health and safety, coffee and cigarettes before work while you do your arm circles. But the concept was good, and we've actually instilled to this day, we still use that advantage of loosening up your muscles to try to reduce your exposure to strains and sprains. But we still encounter it, and the advantage we found in working with a group like Memphis or Mid-South Orthopedic Rehab is to address the problems before they become a recordable injury, or before we have to turn it over to the workers' comp carrier to deal with the actual torn ligament or the slit disc. When we start getting word that an employee is experiencing some pain, you may not even be sure where it started. It may have started on the softball field or lay inside in his yard, but he knows that he's still exerting himself physically at work and it's aggravating that condition. And if we can get that information before it turns into these punitive numbers, and they really are punitive, they're used against employers. If we can intervene at an earlier level and go and introduce them to Memphis Orthopedic, I'm sorry, Dave, I keep mixing you up with the other guys, Mid-South Orthopedic Rehab, then we can hopefully head it off at the pass, because their techniques are, David will explain what his techniques are, but we've seen probably, we were counting them on the way over here, we've probably over the last couple of years sent 9 or 10 folks to them, and a couple of them, they just wanted to go the traditional route. They wanted to go see an actual orthopedic surgeon and do all the diagnostic work, and the end result was the same. They weren't able to help them, and whereas the physical therapy methods that David uses would have. But all the others, we had great success because they were getting some individual attention that they wouldn't have gotten otherwise. We were validating their felt needs. They're experiencing pain at work, and we were able to kind of steer them in the right direction. And it's cheap money for the owners of the companies, to foot the bill for a few of these visits to try to get somebody straightened out, as opposed to having to deal with the long-term effect. This number, this TRIR, affects you just each calendar year, but the first number I showed you, the experience modification rating, has a 3-year tail on it. So from the time you get that claim in that accident year, for 3+ years after that, it's going to affect how people view your loss experience. So that's our involvement and how we've come to know David and Jason and their work, and it's the opportunities that we look for, and we'd be happy to talk to you some more about it, the individual success stories that we've had, and how we get them plugged in and how they make them better. And I'll tell you, one of the before David comes up, one of the best things about what they do is, if any of you have been to a doctor, to a specialist, then you kind of know the assembly line. I mean, you may have a really good doctor, but for the most part, you get to the waiting room, you wait your hour, then they take you back and get your blood pressure, and then they send you back. It's just all the back and forth, and then after all that rigmarole, you get 5 minutes with a doctor. That's what you hope to get. But when we send an employee to David, they get 30 or 40 minutes with the man that's paying very close attention to what their needs are, and sometimes just that psychological benefit alone is enough to make a difference, and all of it helps us control these costs for our customers that we work for. So I'll let David tell you how that happens after we turn them over to him.
Well, thanks for that. Now I can only be a letdown to you after that. So as Cory talked about, there are incident reports and there are things that come up that affect bottom lines for business as well as the employee. And it's little things that oftentimes can have the greatest effect. And Jason Ward and myself, a little over 8 years ago, started our own practice. And we went out and opened our own practice. The intent with opening our practice was to do something a little non-traditional. Now, we're both traditional fellows, so for the two of us to go out and do something that was a little different seemed kind of funny to both of us. But in the healthcare world, this is really bucking the system. But yet it was practical, there was research behind it, and it made perfect sense. And we felt like we could have some positive effect. So simple things like Shelley mentioned, not being able to get out of bed and getting on the phone to help her, while that may sound foreign to folks, it's perfectly natural for what we do. Or her mother who can't put pressure on her knee because she's been over in her back, to straighten her back makes perfect sense to us. So the question that most people often ask us is, why do you do what you do? What is the interest in changing the way healthcare is performed, and more particularly helping businesses? Why would you want to help business and their employees and the consumer? Well, I like that question, why, and why change particularly, and it reminds me of a story about 3 hikers as they're walking by a river. They're walking, they're cutting up, having a good time, and all of a sudden they hear some screaming in the background, and they hear some kids making a bunch of noise. They think they're playing in the river, but much to their distress, they find they're actually going down the river and they're about to go over a waterfall that they were all about to hike to. And so everybody starts freaking out. There's all these kids coming down the river. You've got 3 hikers going to see the waterfall, and they know the waterfall's right there, so there's a little bit of anticipation. And they all run to the edge of the water and start pulling kids out. So there's chaos, there's mayhem, right? You've got one person pulling out the other kid, then you've got kids getting past the group. So you've got one person running with a stick trying to pull the kids out before they get to the waterfall. And all of a sudden, 2 of them are breaking a sweat. They're working as hard as they can, and what do they see? They see one of their friends swimming upstream. They say, what in the world are you doing swimming upstream? They're yelling at him, we need help right here. All these people are coming to us. All these kids are about to go over the waterfall. And he yells back and he says, I want to know where the kids are coming from. So it makes sense, doesn't it? We need people that are going to pull people out of the water, but if we don't look upstream to where they're coming from, then what ends up happening is we get overloaded where we are. So let me ask you a quick question. How many of you have had back pain in this room? Good. How many of you had shoulder pain? Good. How many didn't raise your arm because it hurt, right? How many of you seen a physical therapist for back pain? How many of you seen a chiropractor for back pain? Massage therapist? Your primary care physician? Acupuncture? Yeah, everybody raised their hand for everything. So you have all these different groups of individuals treating pain. So when someone has an injury or has a problem, you have many people to go to. And it can be helpful, but many times what we're doing as healthcare practitioners is we're just simply pulling people out of the water after the problem's already developed. We haven't looked upstream to see what we can do to change the problem. We're giving medication, we're doing surgery, we're giving injections, but we're not solving the underlying issues that are causing these things to recur, what the person's doing and how they're doing it. So I love what Desmond Tutu said, and he's not necessarily in healthcare, but his quote kind of fit the story. He said, there comes a point where we need to just stop pulling people out of the water, and we need to go upstream and find out where they're falling in. So what I'd really like to do the next few minutes is just kind of give you the understanding of why we're doing what we're doing, understand a little bit about the current healthcare market so you can understand the reasoning for what we're doing, the early care for musculoskeletal pain that we would like people to start incorporating for those that are injured, the communication that's so important to make people better, but also to keep them well the long term, and to change the mindset of just getting care because you need care to an outcome-driven care, getting people to the right place at the right time for the care that they need. So if you look at the current healthcare market, or if you've thought about it, if you've ever had a back problem or a knee problem or a shoulder problem, you probably sat on it for a couple weeks to see if it would go away. And most of us do that because of this little cartoon. We want to know, is it an affordable diagnosis that we have? Right? So before we go down to the doctor and go through a slippery slope of tests or medications or things, we often want to know, is this going to be affordable? And this is often a question that we have now in workers' comp arenas and even in self-insured companies who, like Shelley said, are paying dollar for dollar. They want to know, how much is this going to cost us? Because this cost can be significant. I know of one firm in the community that puts aside $40,000 for one of their employees that has back pain. They do that because they know it could turn into surgery and other things, so the cost can be very high. Now, most people don't think of musculoskeletal problems, which are muscle, bone, disc, joint, those kind of problems, strains and sprains, for instance, musculoskeletal. They don't think of that as the major issue in healthcare. We oftentimes think of diabetes, which is a $245 billion problem. We often think of cardiac issues, heart attacks, blockages as being a huge issue, and that's $444 billion of our healthcare every year. But if you look at the cost of musculoskeletal care, it's significant in our country. Last year it was over $870 billion. That's 4 times the amount of diabetic care. And the direct cost of that's very high. So if you actually go see a doctor, have an x-ray, the direct care is there, but you can see that there's a large discrepancy in the direct cost versus indirect, which is time off work, presenteeism. I don't know if you've ever had pain where it distracted you from doing your work, but you're sitting there and you're not being as efficient or as effective as you want. So they calculate that all into the cost. One in 2 adults over 18 have some type of musculoskeletal pain, and if the research is true, 40% of us sitting here right now will have some form of back pain, and 20% of us will have some form of shoulder pain. If that's the case, please see me afterwards. I'd love to help you with that. But 20% of the billion visits that are seen every year in primary care physicians' offices are musculoskeletal problems. So there's definitely a high cost, and there's a need to do something because the cost is going out of control. So I wanted to talk a little bit about individual cost and why there was a need to change things. If you look at imaging, for instance, imaging is a great example of where healthcare is having a big issue. The reason being is even the American Medical Association is telling doctors they need to stop imaging people so much. Now there's a time and a place for it, don't get me wrong. All these things there's a time and place for, but it's often overutilized. And in the case of muscle and skeletal pain that's come on for a non-traumatic reason, for instance, Cory mentioned a gentleman bending over just a minute ago and his back going out. That's not necessarily something that you would jump on and do an x-ray on. Just like if you just tweaked your ankle walking, rolling in your high heels, you wouldn't run to the emergency room for an x-ray. So there are certain things that we want to look at without images. And some of the reasons are, what we're finding is if you take 100 people without pain and 100 people with pain, you're finding the same findings on MRIs and x-rays, such as arthritis, bone spurs, disc bulges, things of that nature. So now what we have to determine is the relevance. And people ask me all the time, well, explain that to me, David. Why is it that you have to determine the relevance of something? Well, I love to use my friend Neil Young as an example. If you remember the rock star Neil Young, back in the day, he had nice skin, long hair, good-looking guy, rock star, everybody loved him, right? But over time, things have changed. Neil is now old, right? He's got a double chin, he's got baggy eyes, he's got gray hair, he's got wrinkles. Things have happened. He's got wrinkles and gray hair on the outside. Well, how many of us, if we took a picture of when we were 20 and compared it to what we look like now, would look the same? Everybody evidently, right? No, well, if we did the same thing on the inside, it's different. But for some reason, when we get a picture taken of our inside, we seem to believe it should look like what we did when we were 20 or 10 years old, and the reality is it doesn't. We all have lumps and bumps and wrinkles and things of that nature on the inside that aren't normal. Now the question becomes, is it relevant to the problem? And that's where healthcare is missing the boat. We find pictures and we start seeing problems and we want to cut it out. We want to do injections when it may not even be the problem. So instead of looking upstream, we start taking care of things downstream. Medication is another issue. Opioid medication, pain medication is overly prescribed. This is something that the American Medical Association is really working hard on. 25,000 deaths due to painkillers last year. The prescription rate of it's so high. They are trying to crack down on that. But the overutilization and cost of these things are significant. And what we're finding is the outcomes with them are worse. People are developing more addictions, more problems, and actually pain levels get higher the longer people are on pain medication, not lower. So what they're being used for is actually not changing the effect. It may give them temporary relief, but not sustained. So medication's not quite fitting the bill for these issues. Primary care visits and doctor visits, these visits can be costly. Most people, and what we've learned with doctors because of a research study in the 1960s, think that back pain and shoulder pain just go away on its own after about 3 months. Well, the big reason is for that is recent studies have shown that people stop going back to their doctor because their pain continues. So the medicine they've been given and the treatments they've been given don't get better, so they just stop going back to the well, if you will. So we're not actually seeing pain go away, we're just seeing people stop going back to their doctor. And this is a problem because that incurs cost as time goes on, because now they have to go to pain management or have further tests or even surgery. If you look at surgery, surgery is high cost, so it's kind of like the waterfall. If you've got someone going downstream and they've gone past all the immediate treatment and now they need surgery, with the images not being relevant or possibly not being relevant, if we cut on the wrong thing, where have we left that person? Possibly in the wrong boat as far as their pain. And I'm not saying we're missing the boat here every time, but in the grand scheme of things, we're seeing that most surgical cases like lumbar fusion, they're increasing 500% over the last decade, but we're not seeing a change in the results or the outcomes that we've expected with that high increase. So we've got a big rate of surgery, a big rate of medication and images, but the outcomes we want in musculoskeletal care aren't any better. In fact, they're getting worse. Joint ventures, hospitals buying up doctors, referral for profit. We mention these things and see this affecting cost, especially for employers if they send their employees somewhere. So just as an understanding, and I can pick on my own profession, if we have extenders of care, in other words, if I have an aide or assistant, what the research shows in large studies is that the outcome quality that you have at your clinic is going to be worse if they're seeing an assistant or an aide, because they don't get the same assessment, same treatment every time, and up to 12 times worse. This isn't a little bitty number. These are big numbers that we're seeing. So, seeing someone who's independent, that doesn't have a referral for profit mentality, and also seeing someone who's going to work one-on-one, like Cory mentioned, to take care of that need and assess it every time, has been shown to reduce cost and reduce the need for issues in the past. So the question is, do we keep doing the same thing we've always done and going insane, or do we make some change? And this is where Jason and I decided to break out and do something a little bit different. The other issues that's occurring with healthcare right now is because of cost. Someone asked me earlier about the average cost or deductible. The average deductible for most Americans right now is $1,250. And this is leading to an issue not only to individuals but also employers, because 30% of people are skipping care because of cost. They'd rather not go see a physician or someone else in the healthcare profession because of the cost. Now, imagine if you're an employer and you have someone who's had back pain for a couple months, but they didn't want to foot their own bill, and now they injure their back at work. This can become an issue. This can spiral, and it can be a high cost issue and affect those numbers that Cory was talking about. And this is a real problem. These numbers have skyrocketed the last 10 years with the cost of healthcare going up. So traditional algorithms typically have folks going to whoever. It could be primary care, it could be a physical therapist, a chiropractor, massage. It could be a number of different issues for back pain or not. And if there's anything sinister going on, like a cancer or a tumor, then adequately we'd want it to be imaged or taken care of. But majority of the issues with musculoskeletal problems don't need that. And so the traditional model we're finding is very costly. It's affecting employers, it's affecting employees because of the cost, and then just us as general consumers as well. So what do we do to change this? Because what we're learning in the general arena now, that unnecessary tests or procedures are being performed all the time, and we need to do something to change that. So the solution, part of the solution is understanding the crisis and the problem, like we just mentioned, but the next part is early care. Now, I am a physical therapist, that's my disclaimer here, okay? And I am all for physical therapy, but I love the research that's behind physical therapy. John Childs just this year did a study of 800,000 military personnel with back pain, and they looked at the prevalence or the number of people who had musculoskeletal pain, back pain with joint disorders, disc disorders, nerve disorders, muscular disorders, versus cancer or something going on like a kidney stone causing back pain. And 98% of these 800,000 military personnel were musculoskeletal or mechanical pain. Less than 2% was something going on in their stomach, their kidneys, and cancer was less than 0.5%. Now, that doesn't mean that we need to overlook that 0.5%. I'm not saying that. We need to make sure we're looking for that. But the signs and symptoms that we'll see in the clinic are completely different for that person with something sinister than a musculoskeletal problem. So the assessment can easily weed those out and get people moving in the right direction. So he said, hey, we've got a high prevalence of mechanical issues, but only 7% of those people are getting to a physical therapist for mechanical problems. So we're treating a lot of people downstream. We're not getting them to a mechanical therapist to look at the mechanical issues to take care of the upstream issues. So what do we do for that? And this is just a study that Mayo Clinic did that looked at the top 3 reasons people see their doctors. Skin disorders, number 1, back problems, number 2, and joint disorders, number 3. A couple of studies, I don't want to go into detail too much, but I want to give you a couple of studies about why early care with physical therapy has been shown to be beneficial. University Health System in San Antonio started getting anyone with back pain to their physical therapist within the first 3 days that they walked in the door. And if they did that, they saw a reduction of cost by $1,500. They reduced visits of physical therapy on average from 14 to 15, and they saw their x-rays and MRIs, images go down 50%. So there was huge cost savings for the person that was coming in for the back problem, much fewer visits, and they were also seeing significant cost savings downstream as well because they weren't needing the MRI and other studies. There was also a study done by Virginia Mason. Virginia Mason is a large hospital system in the Northwest, and they work with large employers, Costco, Nordstrom, Starbucks, and Aetna Insurance. Those are large players. And they were looking at major pain points for them as far as cost, and musculoskeletal problems, specifically low back pain, was one of their biggest issues. And so what they did is they sent everybody to their work doctor as they had to, and as long as they had no red flags, signs of cancer or anything sinister going on, they sent them directly to the physical therapist within the first few days. If they did that, they saw half the visits of therapy compared to the area. They reduced imaging, MRIs by a third. The average work day or the time off of work that the person had reduced by almost half, so they were getting people back to work faster. And they were achieving high satisfaction. And one of the biggest tells of this was the cost savings, almost $1,200 to $1,300 in cost savings if people went to physical therapy first compared to going the traditional route. A study that was done by physical therapists looking at 32,000 patients also saw if we got people in early, you're going to reduce the likelihood of imaging by 34%, seeing multiple doctors by another 25%, surgery by 45%. That's huge. If you can reduce surgery by 45% just by seeing someone within the first 14 days, that's huge. Injections reduced 42%. Probably the number that's most staggering to me is the likelihood of needing pain medicine reduced almost 80%. Just if you got somebody to mechanical care early to deal with the upstream problem instead of letting it go downstream. So huge cost savings, huge changes in what we're seeing in healthcare. And the cost savings on average for these 32,000 folks was $2,700 if they got to PT early. So there's huge change, huge cost savings. Now, it comes down to the point a lot of times where people feel like they need to have surgery. Okay, I've had an MRI and it did show a bulging disc, or I do have a full thickness tear rotator cuff. They said my rotator cuff is obliterated, or yeah, it did hurt my knee at work and I need to have surgery. Well, the last 5 years have been very interesting because of those MRI studies I mentioned to you earlier where we find a lot of wrinkles and gray hairs. We need to know what's relevant or not. They've started comparing studies of folks who just have physical therapy to those who do have surgery and seeing the outcomes at 2 years. And it's pretty amazing. If you have cervical fusion at 2 years, the outcomes are just the same as those who had physical therapy. Pain and function scores. And the cost difference is 6 to 8 times more just for the surgery compared to physical therapy. That doesn't include hospital stay, medication, or visits after. So huge savings. Now, just because of time, I'm not going to go through each individual study, but I will have these studies available for you on a PDF that I'll send out and email to you if you like after this. I have each study listed so you can see the references and some quick details about this. The other is rotator cuff tear, whether it was a small tear or a full tear. If we got people into physical therapy and we treated that issue first, 3/4 of these people, even with massive tears, were not needing surgery at 2 years and back being pain-free. So some significant changes. So the cost is much less and the side effects are much less as well. Lumbar fusion, we see the same thing. Outcomes at 6 months and 2 years and 5 years the same. ACL reconstruction, same. Knee scoping, outcomes same. In fact, there's been 4 studies on that here in the last 2 years. Achilles tears, there's actually some good studies showing that if you have an Achilles rupture, if you have physical therapy, in 2 years the outcomes are the same as those who just have surgery. So it's very interesting. Not something we often think about with massive tears, but yet the body has an amazing ability to heal if you treat it right and you take care of the upstream problem. We also see the same thing with injections, so cortisone injections, getting people into early care. The outcomes are better if they don't have the injection. And then MRIs, we talked about that a little bit, but if folks get to therapy early on, there are cost savings of over $5,000 compared to those who have images up front. So it's more costly to have a picture, believe it or not, than if you don't, and the outcomes are just as good. So the next part of the solution, we've got understanding the current system. The second part was what we just talked about. The third is the solution of proper assessment. The biggest issue that we have when it comes to conservative care is assessing patients properly, making sure that they are doing the right thing to address their problem, not just giving them random exercise or things of that nature. And that's where mechanical diagnosis and therapy comes in, which I'm credentialed in and Jason is as well. We've done postgraduate training extensively in looking at how do you fix upstream issues. So if someone comes in with back pain who can't bend over, can we show them a position, movement, or technique that can change that quickly? And if we can, then the likelihood of them getting better is much greater. And we have research to demonstrate that. In fact, Jason and I have been involved in 2 studies showing if we see certain changes in the assessment, that person won't need surgery, their pain level will be better, and their function will be better. And those things that we're looking for in the assessment are based on 2 things. One is centralization. Centralization just simply means the more irritated something is, the greater the pain and the more it refers. I don't know if you've ever been injured really bad, but a certain area, if you've damaged it, is going to hurt not only in that area where you've damaged it, but it's going to tend to radiate out around that area. But if you do the right thing to allow it to heal, that pain doesn't stay everywhere. It starts to become more narrow to where the problem came from. And we'll see this very commonly in the back, where someone has back and leg pain, and you get them moving in the right direction, doing the right things, and their leg pain goes away. The pain centralizes to their back, and then it goes away. Same thing in the neck and the arm. Very high prognostic indicator. In other words, it shows us statistically that we're going to make that person better without surgery if we can find that. There are multiple research studies by a gentleman named Mark Warnke, and I have those listed in the PDF for you to look at that show significant reduction in surgery, the ability to differentiate a painful disc versus a non-painful disc with this symptomatic response in patients. So it's a very powerful tool, just understanding a person's pain, where it is, and if it changes based on what we do. And the beautiful thing about this is only the person can tell you if it changes. Practitioners can't tell you if it hurts and where it hurts. We have to listen to the patient. This is a huge issue. Listening, I'll talk about communication in a minute. The other is directional preference. All this means is most people get better with certain directions. For instance, if I have a cut on the back of my knuckle and I bend my knuckle, I'm going to split that cut wide open if it's fresh, right? So we have a preference when we cut our knuckle, right? It's to straighten it up and put a Band-Aid on it. And that makes perfect sense. We walk around for a few days like this doing stuff, but we don't avoid bending the rest of our lives. We get back to bending once that cut is healed because it makes perfect sense. We can see it. So if we can see it, we're better believers, right? Well, if things going on inside our body give us indicators that it's healing well. For instance, Cory mentioned the young man who gets stuck bent over. I happened to see a guy from Cory who was stuck bent over. He couldn't rise when he would come up. I could show him one movement that could straighten his back up immediately, and every time before he performed that movement of bending over, he could do that one stretch I showed him and it didn't make him stuck, and he could do it every time. So we were able to give him a directional movement that fixed his problem and helped him sustain, and now he had a way of carrying it over at home. A huge indicator that they're not going to need surgery, a huge indicator that that person has the ability to heal, and a huge indicator that that tissue is competent to do what it's supposed to do without needing to go further into care. This is a big thing. If you can see this in the assessment, it gives hope, not only hope to the patient, but also gives them confidence that their body can heal and move in the right direction with conservative care and things sometimes as simple as exercise. So we've proposed changing algorithms, and this is what we've done with Cory and their group. Instead of having folks going through the traditional model where they're going to end up having a primary care visit or a doctor visit that turns into 2 weeks of medication, maybe an MRI, maybe this, maybe that, and then to see a specialist. And now we've got 12 to 15 weeks of issues. They're coming straight to us so we can look at mechanically, Are they one of those 98%? Can we take care of that issue quickly? And if we can we deal with that upstream problem so it doesn't continue to go downstream? And we're doing this now since 2007 under provision made for direct access, which means physical therapists do not have to have a referral for physical therapy in the state of Tennessee. So that used to be a question. People would think, I have to have a referral to see a physical therapist. Over the last 7 to 8 years, we do not. So people can come to us directly, and that frees up the burden that there used to be for people to come see us. So next part of the solution is communication. I heard a funny story the other day about a man whose wife just couldn't hear worth the flip, and he didn't know how to tell her that she couldn't hear very well. So he asked his doctor, he said, "Doctor, please give me a way to figure out how I can tell my wife that she doesn't hear well so she doesn't fuss at me." He said, "Okay, I'll tell you what you do. You do the 60-foot test." He said, "What's the 60-foot test?" He said, "Well, you stand 60 feet away from her while she's cooking dinner, and you ask her, just in a normal voice, 'Honey, what's for dinner?' And if she doesn't answer, step up 15 feet. And do that every 15 feet until she can hear you, or you can hear her saying, 'What's for dinner?'" He said, "That's perfect. I can come back and tell you where we are on that scale of 15 feet, and you can help me out." He said, "Perfect." So he gets home that night, he stands back 60 feet, and he says, "Honey, what's for dinner?" Not a word. So he steps in another 15 feet. "Honey, what's for dinner?" And you can imagine what happens. He goes from 45 to 30, 30 to 15 feet to the point where he's finally behind her, and he goes, "Honey, what's for dinner?" And of course, she turns around and says, "Chicken, for the 5th time, chicken," right? So the communication part of what we do, yeah, you'll catch on to this in just a minute, okay? It was him that had the problem the whole time. And this is the biggest issue in healthcare is communication. Most patients aren't being heard. We're not listening to their symptoms, we're not listening to what's going on with them. We feel like we know the problem when the patients really do. Communication is key, and this is one of the things that Jason and I are doing recently that's new. We've developed, or not developed, but we've started a new EMR system that allows us to connect to patients online through their phone, through a web browser, in any way that they can securely get a hold of us whenever they need, however they need, by direct messaging, by telecommunication or telehealth, or even just secure email. We feel like that's very important for someone if they have back and leg pain, if their leg pain is getting worse, that we can address that issue quickly, not wait another week or two to take care of it. They can also schedule visits. That's important. If people have a back problem, we don't want them waiting 30 to 45 days to get in. We want them to get in early, like we mentioned, so we can take care of that issue. So the earlier we can get them in, the better. Plus, we want it to be secure and follow HIPAA, not to be HIPAA non-compliant, but compliant, and this allows us to do that even with telehealth. It also gives them online access to a library that has their exercises on it. So if we recommend someone do something or we give them an educational video, they can actually log in, watch that video, have those exercises there whenever they need to, and it's secured. So a quick picture looks something like this, where this gentleman was able to log into his exercise file and pull up his exercises to see what it was that we discharged him with. There's also an educational video in there about back and leg pain that I was able to put in there for him to watch when he got home because it was 10 minutes long. It allows him to have those tools to look at, and then he can communicate with me through that if he has further questions or concerns. And this is a recent telecommunication or telehealth visit that I had with a gentleman that I saw in my clinic for knee pain. He was in Washington, D.C., and we did a follow-up just last week. Had him doing something to squat down and check out the effect of his knee. But it's something that we're able to do now to meet that need early instead of problems festering or lingering. Just a different way of communicating and working together. Last thing I want to talk about, because y'all have been very great to listen well so far, as part of the solution, is outcome-based care. And I have one more story, and I know I'm full of stories, but just one more. It's about a guy named Jim who's playing golf. And Jim had the worst time hitting the ball. In fact, he was trying to get on the PGA Tour, and because of this, he was really doing everything he could to get on. But he could hit the ball with a flip. He was hitting the ball left and right everywhere. And so Jim went to a sports psychologist under the suggestion of a friend, and the sports psychologist said, "Have you tried everything?" He said, "I've tried everything." He said, "Well, I've got one thing for you to do." And he said, "What's that?" He said, "Jim, I want you to play golf without a golf ball." Jim looked at the sports psychologist and said, "What in the world are you talking about? Play golf without a golf ball? That sounds ridiculous." He said, "Well, here's what you do. You tee up your imaginary ball and you imagine where you want the ball to go." He says, "Play around like that and see how it goes." He says, "Fine, I've tried everything else, I'll do it." So Jim goes to his favorite course that afternoon, tees up his imaginary golf ball, and lo and behold, his first hit, he imagines it going right down the middle of the fairway. 280 yards, perfect. Third hole comes around, he's playing well. Fifth hole, best round of his life. 17th hole, he realizes that there's another guy in front of him that's also playing without a golf ball, and he thinks, it's the first time I've ever seen that. This guy must see the same sports psychologist. I need to catch up to him. He's playing the best round of his life. He gets up to the 18th hole and he meets Bill. Bill is also seeing the same sports psychologist. Bill is also having the same problem. Bill is also having the round of his life without a golf ball. In fact, Bill's feeling so good about his golf that he says, Jim, I'm going to bet you $100 I can beat you on this hole. Jim says, I will take that bet because I'm having a great day. Bill says, I'll even tee off first. He says, perfect. Bill gets up, hits his imaginary golf ball 300 yards right down the middle, perfectly placed for this par 4. Jim gets up and hits his golf ball. Imagine this, 300 yards right down the middle. In fact, they talk about it being in such a close proximity, they don't know who's going to hit first. Bill says, well, since I've placed the bet, I'll hit first. So Bill gets up and he hits his ball. He hits a perfect shot 5 yards past the pin. He's describing this to Jim as it backspins into the hole, and he screams and he proclaims that he's won. He has victory. He says, I've won. I've got an eagle. You can't beat that. He says, this is my hole. Give me $100. And Jim said, not so fast. Bill said, what do you mean? He said, well, you just hit my ball, right? This is a lot of what's going on in healthcare. We have a lot of people saying that what we do is best. We're providing the best care. There's no tangible evidence that they're hitting the right ball, that they're doing the right thing. Everyone believes that what they do is best for the patient, but there's no tangible proof that people are moving in the right direction in healthcare, and this is part of the problem. So what Jason and I have been fortunate to do is get involved with a company called Focused on Therapeutic Outcomes. They give us tangible evidence that we're at least hitting the ball down the middle or we're shanking it way right. What this allows us to do is get the patient's perspective of how they feel and how they're doing with their care. So they answer some questions based on risk-adjusted data. What that means is if I see a bunch of patients that are 10 years old with back pain, they're probably going to be a little different outcome-wise than all the 80-year-olds with back pain for the reasons that 10-year-olds aren't going to have what are called the same comorbidities like diabetes, heart disease. So it adjusts for those factors. It puts everybody on a level playing field. We have about 8,000 clinicians in the United States. They do all of Canada's physiotherapy and Israel's physiotherapy, and they measure number of visits, the change in patients' perception of function, pain. They can also look at depression and somatization. And what that does is it gives us good feedback and tangible evidence that we're moving in the right direction with those folks. So it gives us a way to say, yes, we're doing the right thing with this patient. We're seeing the right changes that we're looking for. And it gives us patient perspective. So outcome-based care is very important. You need some type of tangible proof that you're doing the right thing, not just because I said so. And this is what we're looking to do. So we're trying to encourage folks to change their model a little bit, change their thinking towards healthcare. Get to someone who's in private practice. The reason being is they don't have a referral for profit agenda. Go to someone who's highly trained and credentialed in mechanical diagnosis and therapy because they're going to be looking for those things in the assessment to deal with the upstream issues, not just letting things go downstream like we talked about, and not having lesser support. So you need to be able to see your therapist or whoever you're seeing every time because you're going to get better quality that way, and the research shows it. And then also getting greater improvement. That's one of the things we've been fortunate to over the last 6 years. We're seeing people on average 4 visits fewer, and we're getting 73% greater outcomes in the fewer visits than national average because we're doing these things that the research shows. And this is what our scorecard looks like. Photo does this every quarter for us to give to our employers. We can give it to employees. We can give it to insurance companies. It's a scorecard that shows if we're above or below the national average. It gives us some tangible evidence of how we're doing comparatively to others across the country and across the world, and also in our area. So it gives some tangible proof of what we're doing and how we're doing it. We've had the good chance of doing a lot of fun things from research to treating folks in this room to working with Cory and others. And I really appreciate your time this afternoon listening to how we're looking at changing their traditional model in a way that does meet high standards, in a way that's very effective and efficient, and is very patient-centered. So what I'd like to do now is bring Cory back up here, and we'd love to answer any questions that you guys have, and we'll go from there. Thank you.
I had the first question. Why did you all nod politely at my poor multiplication and math skills?
It's because I'm from Louisiana and I had no idea that was wrong. Any questions that y'all have? Yes, ma'am.
Question from Cory. You were talking about the FedEx forum work people who had to be there at 6 a.m. to
Right.
stretch or whatever. Is that something that an employer can require of the employees, and if they don't comply, will it affect their ability to get treatment for workplace injuries?
Well, I think you might have a tougher time implementing it in a union shop versus a non-union shop. In a non-union shop, you can require your employees to do whatever you think the job description should be. The caveat would be creating a program that doesn't set them up for workplace injuries. So maybe mandatory is not the right answer, but encouraging it so that, you know, you get enthusiastic participation that would actually be productive, instead of having that one disgruntled employee that uses that mechanism to actually have a workplace injury.
Yes.
For Cory, kind of related to what she was asking, but is there any research that shows that workplaces that start later in the day have fewer incidents because people are awake longer and moving about and they're warmed up in their muscles and joints before they get to work than those that start early in the morning?
And if you'll repeat the question for the camera.
Yeah, I'm sorry. He's asking if there's study that showed that the time of day, the shift work, perhaps the second or third shift, there's fewer incidents because they've had time to warm up their muscles. And there are studies that actually show everything depending on what you're trying to demonstrate. But I think it is true. In fact, we've had people in this business and David's and Jason's business tell us that actually doing the stretch and flex routines are sometimes better at the end of the day instead of the beginning of the day, because the muscles have had time to warm up, they're more elastic, and you get more benefit from doing those stretches. So the same would probably be true for shift work if they actually aren't sleeping right up until the time that they begin that shift.
And the reality is also true for sitting workers too. They sustain a position for a long time, they need to move up and get up and move frequently.
Question for you, David. This proactive telehealth, I hope that becomes a trend. To me, that early detection, solution-based therapy that you're doing early on. Have you been able to cite or compare your ability to treat people early before the pain became chronic versus somebody going to a regular, waiting for a couple of months before they actually were seen by a doctor, and the time that they had to go through that care with a regular doctor versus you're being able to treat them early and go through that process at an early stage rather than a later stage of that pain?
And so the question is, do we have any research to compare what we're doing to traditional care?
Right.
Is that right? The research we've been involved in is more looking at the assessment process and to see if there's any indicators that someone's going to get better with the assessment. And if we see centralization directional preference, and it does. The best study that I can give you on MDT care, and there are numerous studies that show if you see these different things in the assessment that they're going to be less likely to need surgery, better indicators are going to function well. But a study that was done with Michelin. Michelin's one of the largest manufacturers of tires, of course, in the whole world, but one of the largest organizations in the whole world, the MDT care. They've seen a change in their musculoskeletal surgery, for instance, being 1 in every 7 every year to 1 in every 120 if they undergo this first. Length of disability reduces almost by half, and that's saving the employer over $100,000 or close to $100,000 a year per employee, or excuse me, $800,000 a year per every 100 employees. So there's significant reduction of imaging, cost, surgery, if we implement these things early.
It seems like a common sense approach to it. I would think that.
I think that's why we don't like it here, is because it's common sense.
Well, because I look at pain management. I mean, you get the physiological, plus you amp it up with the psychological. And to me, early detection, first strike advantage, and you can demonstrate and work through some of those therapies early on. You're giving the patient, there can be a way out here. It doesn't have to be a crash and burn, and you're giving them a solution orientation early on. To me, that's is very significant.
And to that point, I think the biggest issue is what you're alluding to is self-management. Not only, hey, what can I do for you, but what can I show you to do for yourself to maintain? And probably the easiest example I can give you is going to see your dentist. You know, after you go see your dentist for your 6-month checkup, if you have cavities, he fixes that need. Or if you have a cracked tooth, they fix that need. But there's 3 tools that you get every time you leave your dentist. You get a toothbrush, toothpaste, and floss. And he tells you, do these things twice a day so I don't have to keep drilling in your mouth. And you know what? It can be 1 o'clock in the morning, you fell asleep on the couch, but before you go get in bed, groggy-eyed and everything, you'll go brush your teeth, right? And so some people kind of have the same idea. They did a study because the recurrence rate of back pain is 70% within a year if you don't do anything for it. And this Michelin study was one that looked at recurrence rate, but also one other study that was cited that if you got people on proper directional movements, kind of like talked about the directional exercise, and show them how to do that on their own and teach them to quote unquote brush their back a couple times a day for maintenance, the likelihood of recurrence goes from 70% to 10% in one study. And in the Michelin study, 60% to 5.5% for those low back pain. So brush your back a couple times a day as well, okay?
That's a good takeaway, Dave.
Yes.
Every time I hear you, I learn something more. I've never heard you speak this long. I just got to ask, what is it going to take? I mean, why is it that this is not better known? What's it going to take for people to go, oh my gosh, it could have had a V8?
So what is it going to take for this to take off or be known? Individuals like yourselves, word of mouth, organic growth. I can go to my physician friends. I have great physician friends, and I can speak this until I'm blue in the face. It doesn't change a thing. Very few, until they actually experience it, do they start changing their referral patterns, because it's not what they've been taught. Maybe getting into the schools would be beneficial. Dealing with workers is huge. If anybody's going to change the way healthcare is done in our country, it's going to be employers, because they truly do have control over insurance companies and others. You get large employers that have control over contracts with companies like Cigna, Aetna, and others. If they can come to the table and say, we want this, or we're leaving, then they can truly change the game. So individuals like yourself, but also employers. I really feel like they can be game changers in the long run to change the traditional method. Yes, sir.
Is there anything different you do when somebody actually has a ruptured disc in terms of treatment? Does that help? with ruptured disc also?
Question is, do we do anything different with someone with a ruptured disc? Is it a painful or non-painful disc would be my question. I'm assuming you mean painful, and I jest and pick on you a little bit. The only reason being is if you're over 40 and have never had back pain, 60% of people are going to have a bulging disc in their back who've never had pain. 1%, 1 out of every 100 will have a completely blown out disc who've never had pain. So the question is, what needs to be done? Is it problematic or not? And so if that person, for instance, to answer your question and not just pick on you because I know you, if they have back and leg pain, if I can find a position or movement that reduces that leg pain and I can get them started in the right direction, then I'm going to have them do that. Now, the good thing about the assessment is if I can't find a way to change that problem, then that person may need to be moved on to further care, maybe an injection or surgery. At that point, we would refer them on to do that. So it simply depends on that person's need and where they are.
So even with this, there's room for physical therapy?
Yeah, everybody is capable of improvement, but until they change what they're doing, we don't know if they're capable or not. But there are key predictors to demonstrate if that tissue is competent to heal or if it's not competent to heal. Good. Thank you all very much. Cory, thank you.